This beautiful August gathering. Good morning to everybody. Dr. Preeta Reddy, Dr. Sangeeta Reddy, Dr. N.D. Trivedi, and my colleague, Secretary, Dr. Pradeep Vyasji, the delegates from the 30 different international areas, more than 2,000 participants in this conference. So I congratulate Apollo Hospital for their elaborative conference, seventh international conference, which is, the subject of this conference is close to our heart. So thank you very much for contributing in the health services and healthcare. I have seen all your conferences which are shown on the screen. So really the patient safety for us is a matter which is most important, close to our heart. And in day-to-day life, the people grumble about the treating the patient. In the big hospital, rightly, Reddy Madam has said about the affordability. You talk about 3 A's. The one of the A is affordability. And the affordability is a criteria which is concerned to all the common person and the common patient. People wants everything in free, and that is government is doing around the 6 crores patients are treated in the government hospital every year. But there is a private setup. We are not in the tertiary care, Dr. Pradeep Vyas has rightly said. But we try to go to the trauma care. We try to go to the SNCUs, NICUs, and try to treat the patient which are in the tertiary stages. At the same time, the hospital infection is a most important part of our treatment part, because many of the patients, they get the hospital infection after staying there for a long days. Recently at Hinduja, we have come out with one book manual, SOPs for how the ICCUs and ICUs should be. What is level 1 ICU, what is level 2, what is level 3. So that is, again, my brainchild. I requested Hinduja Hospital to come out with such kind of manuals so it will be useful for us to possess. We are treating the patient, we are saving the lives. And people don't write the case histories and all these things so meticulously. So I will request that if NABH people are there, I have also requested them officially, that you should cut down the clerical work, you should cut down the histories, don't go into the histories, come to the practical point of view and accredit the hospitals for the NABH standard. They should not mind. At the same time, regarding the hospital infection and other things, patient affordability, so nobody has thought about the infection coming from the ventilators. We always prefer that we should have all the disposables for the ventilators, but when we saw the swine flu cases, majority in the state of Maharashtra, the ventilator acquired infection is also there. AC acquired infection is also there. That has worsened the patient. So this is a practical view. So there should be a SOP, standard protocol system, for how to use the ventilator, how to clean the ventilators, and how to keep the ventilators in the proper form. So these are the basic things. I think this should be contributed to today's conference. Second thing is that when we are in the OTs, we always prefer to have a steel OTs. But the smallest crack, smallest abrasion on the OT wall while taking patient on the stretcher inside, that can also contribute to the bacterial growth. Because we are not noticing that all the joints which should be filled by the silicone are intact or not. After the few years, after the 2-3 years, the accumulation of the bacterial growth is always there. So there should be some solution to these cracks and all these things. So these are the 2-3 points which I wanted to mention in front of you. You will be more elaborative on these patient safety norms. When the patient walks inside the hospital, he should be treated properly. Every time the complaint is about the patient safety, that the patient comes, this is a common thing, this is not related to, but since you are the hospital owner and you are associated with the hospital part of the state, always it is asked that deposit the amount. And patients' relatives get wild on you. And then the conflict starts. So try to get the patient inside. And there should be the person who is handling this type of cases at the desk, at your desk, should be a little bit polite, little bit understanding. That patient is in agony, we should not add to his agony. See, the money has to be paid because you have to run your business. Hospital is an industry, so I don't mind asking for the money. But whenever the patient will be there, please take it little bit cautiously. So the other conflicts, the vandalizing of the hospitals and the other things may not happen in future also. So there should be a training program for this also, how to talk to the patient, how to react to the emotions, how to handle the patient's relatives. There are the conferences. This is the 7th conference. I will request Dr. Preetha Reddy and Sangeeta Reddy that whatever outcome will be there from these conferences, whatever you gather from the brainstorming session of these days, conference day, so please share with us. So whatever the best you found out from this conference, please share with us. It will be helpful for us also. Regarding PPP model, Dr. Pradeep has already said that we are ready for the PPP projects. We need to give all our trauma care centers on the PPP basis so that we can have better things, as well as the NICUs, which we are going to promote in near future. So if anybody is interested, please come out with their proposal and contribute to the health. And it is a great slogan that join your hands for the patient safety. Government is with you, you are with us, so let us do for the patient's benefit. Thank you very much.
Thank you, Dr. Deepak Sawant, for coming and gracing this occasion. In spite of your busy schedule, I know that you have to go to another function also. Next, I invite Mrs. Sangeeta Reddy, who is the Joint Managing Director of Apollo Group Hospitals. She is passionately committed to transforming healthcare using effective and efficient technology, and she has steered Apollo Hospitals to harness technology advancement in accelerating positive transformation at 4 hospitals and have achieved high certifications. Ms. Sangeeta greatly influenced and developed of health IT in India through annual health IT conferences and also by her participation in state and central government endeavors. She is a healthcare evangelist and has started her career 33 years ago, and she maintains the same passion today. I will request her to address the gathering, please.
Good morning, ladies and gentlemen. Good morning. It's a dark hall out there, so I wanted to make sure that you're with us. But I'm super happy, extremely excited to be with all of you once again at this 7th conference on this side and the 8th conference on the IT side, Because I think the biggest power that we have here is the energy of our participants, the dedication of our speakers. Ms. Paula, the CEO of JCI, said this is the 7th year she's been here. That means she's 100 on 100. So she's been here entirely, and that's the same for so many. And it is this passion that keeps us committed to doing this year after year. And thank you all so much. But let me tell you, there's a lot more to be done. We're barely scratching the surface. Honorable Minister, Honorable Secretary, Dr. Trivedi, Vice Chairman, Ms. Preeta, and our Chairman, who I know his heart is here, even though he's physically in Delhi. He'll be with us tomorrow. To all of you sitting in this room, this patient safety moment, this patient safety movement is a series of moments of touching lives, of going in there. Will that nurse forget to wash her hand? Will the doctor forget to call a timeout? Will somebody cross-check when this moment happens? And how can we ensure that every knowledge and power we have is applied to ensuring that these moments of caring translate into moments of excellence, and therefore the ultimate goal that all of us are working for every single day, and that is a happy patient, a smiling family who takes their family member home. Those moments continue to happen. That's what we're here for. That's what we're committed here for. And the 3 A's of accessibility, affordability, we used to say quality, and Preeta beautifully converted that to accountability. I think if we begin to look at quality as an individual accountability, we've done some significant paradigm shift in this story. So with that, let me really begin with our first slide, which is not that one. And can I have the slide changer, please? Yeah. So first slide, please. So it has very, often, and again, Preeta said this, that, we anesthetize a jumbo jet of patients every single day. So that industry, the airline industry, shares with healthcare some very important attributes. They're high stakes. If something happens in a surgery, it's a high stake. If something happens to an airplane, it's a very high stake. We have potentially lethal technology. Can you imagine a chemotherapy drug being given in the wrong dose? The primarily participants of this who contribute to the safety, both in the airline, the pilots, and in the healthcare, are fairly strong-willed people. The pilot also likes to be in charge, and doctors are super in charge. They're strong-willed, they're independent, and they're quick to slip into an autocratic behavior. But also, in an airline, the work is done by highly interdependent groups. You need the maintenance team, you need the pilots, you need the air hostesses. But once you're in the air, there's very little supervision. Very little supervision for what's happening. And that's the aviation industry. However, in a plane, there's a single scenario that works pretty well. If the technology works, the plane is good, you're almost auto-landing itself. These days, I believe pilots are reading storybooks. But additionally, there are only 2 pilots who are driving that plane. So the process is dependent at that crucial moment primarily on them. But in a healthcare scenario, there's an interdependency of so many players. From the biomedical and to make sure the thing is working, but the doctor, but then the handoff to the nurse, and then the junior doctor who has to check it, and somebody to give warning signals. So I would say that the healthcare industry is actually the most complex in the world. But the one important thing is that it is said that every time there's an airplane accident, flying gets safer. Because with that black box and the deciphering, they figure out how to enhance the safety protocols more and more. So the biggest learning for the healthcare industry, which is more complex than the aviation, is let us analyze and learn from our mistakes in a far more powerful manner than we are currently doing, because the risks are equally high, if not higher. I think from this topic of learn from our mistakes, I would really, on behalf of everybody in this audience, share that one aspect. We've moved from the checklist manifesto to protocolization of healthcare to SOPs. And Sir very appropriately observed that the NABH is a lot of data. It's a lot of record keeping, it's a lot of writing, and this is painful for people. And the challenge between, should I write this document or should I actually go take care of the patient? That is the challenge many of us face every single day. But the journey of quality, sir, I think has moved from the first step where there was a checklist to say, do you have the right equipment, the right anesthesia, the right size of the room? Have you checked the leaks in your theater? Do you have a protocol to make sure that the maintenance guy who looks at the oxygen flow is cross-checking? Things have moved. And from standards of equipment and infrastructure to processes. What do you do? What happens in an emergency? What is timeout before theater? How do you cross-check whether you have the right name, right site, right patient? So we moved from infrastructure checking to process checking to now outcome checking. And this journey and thought process is a journey that all of us are traveling together. And so there's a stages of development or evolution in the journey, and we know that right now, 80% of the work that JCI does when they come into one of the hospitals is actually patient tracker. So they've gone back to exactly what you were saying. Take a patient, take the record, take the file, and make sure everything has happened right. But the fact is that everything can happen right when the infrastructure and the process were in place, and then the patient care gets better. So very simplistically, Paula, I hope I've summarized some of the ideology of the Joint Commission, the journey that all of us, many of us in this room have taken, and the journey that NABH is traveling as well. We need those both hands to clap. The infrastructure and the process mapping to come together so that every patient gets that standardized care. And it's a tremendous journey that I think all of us are on. But actually, when you look at it, when this Kaizen of quality tracking is in place, there's other things that I really wanted to share, which was the fact that this patient and the family, the healthcare worker and the community have a joint role to play. The facility, the resources, and the tools have to work together. And the acknowledgement, which our Honorable Secretary mentioned, is that what happens in primary care is a slightly different scenario and focus than what happens in the tertiary care, yet there is a continuum of care that we need to find and work together on. So for this, sir, IT analytics, communication and training, standardized documentation and protocol, timely interventions to do these right. Things like, many years ago, one of our doctors, and the fact is that most of the most brilliant things in quality come from the teams itself. The quality team, the nurses, the doctors. So one of our doctors, and I don't know if she's here today, but it was innovated to say that why do we announce Code Blue? We were very proud of our Code Blue protocol, that everybody rushes, we give the patient immediate care. And she actually said, why do we ever announce Code Blue? When a patient in the ward is deteriorating, he has symptoms of deterioration far earlier. Increased heart rate, breathlessness, discomfort. Can we figure out those symptoms, train our nurses to pick up those symptoms, create a med team or a medical emergency team who goes earlier? So now our announcements of Code Blue have actually gone down. That is timely intervention. That is quality and training, and this again is the journey that Preeta referred to. That there is no destination. Tomorrow we'll be saying med team has no meaning. You should have put a device on the patient and a central team should have put an algorithm, and we should have known that much, much earlier. So this is an evolution, and we're all working on this together. And we are a team that goes to doing this. So from checklist manifesto to protocolization to SOP to outcome monitoring, this quality movement. But I was actually sitting yesterday before I came for this conference, and I said, where is this going? What more can we do? What is the power that we can find somewhere else to apply into this? Because yes, we've done JCI, we're proud to work with the NABH, and all of us together are doing so much. What more, what next, where is the future? And I think that future is not just in using data to predict outcomes, and sir again mentioned this, and I must state that the depth of the comments of the health minister shows the depth of his commitments to healthcare. You spoke, sir, about ventilator-acquired pneumonia. Not only do we have VAP as a technical structure in Apollo Clinical Excellence that we are measuring, not only are our nurses trained in terms of keeping the pipes clean and ensuring that VAP is low, but today, there's a silent project happening which we'll be proud to have, all of you as partners, or we work as your partner. In that, can we predict, because we're using AI and because we understand the symptoms which are happening, can we predict not just ventilator-acquired pneumonia, but sepsis? If we could predict the oncoming of a sepsis just one day earlier and begin that treatment one day earlier, would it radically change the outcomes and the mortality in intensive cares? So how can we use data to marry with this quality movement and use these points of information that the patient is giving out every day, and take best care processes and ensure that those care processes are standardized across, so that an MBBS doctor who graduated yesterday will have at least 80% of the same knowledge base behind him as the doctor who's worked for 20 years. And it is that ability. So I don't call it AI. This is not artificial intelligence. Nobody is going to replace the doctors in the room. But what it is augmented intelligence. Can we take the intelligence of multiple people and put it in the hands of doctors and nurses at the point of care, so that we get better outcomes, so that our patients recover better, and we always remember that smiling face of the patient and the family. That's the journey we're on together. And my last point is really, how can we take this away from just a conference that we love to meet every year? How can we make it beyond the few webinars and the physical conferences? The power of social networks and social behavior is transforming public and private. It's transforming the old and the new. Grandmothers are connecting with their grandsons who are studying in the US. But more than anything, the mobile phone and the social network has become a part of our lives. I'm proposing here, ladies and gentlemen, that together we create a quality club which is a social movement. So if we have a fabulous ventilator-acquired pneumonia protocol, we take a video right there, we put it. 250 people see it, 350 people share it, and many others like it, or whichever ratio that happens. This is a continuous movement. But this ability to use awareness and screening, diagnostics tools, health awareness, patient education, disease management, hundreds of protocols towards the better population health by creating a social network of idea generation, of acceleration, and then a strategic compass that pointing us in the direction of patient safety is really what I'm proposing. I believe that this movement will happen and be born today and tomorrow with the Patient Safety Club. So please sign up for that Patient Safety Club. Please be a member of it, a contributing member. This is not just the Uberization of healthcare. It's not just the democratization of healthcare. It's our ability to stay connected, which will then create the transformation. It's wonderful to see all of you here. We thank the Minister and the Honorable Secretary for being here. Participants in this program will be signing, sir, the Mumbai Declaration. The Mumbai Declaration will capture all the deliberations and what we want to do together. It will be handed over to you as well as to the Honorable Minister J.P. Nadda ji. Tomorrow, Ms. Patel is also coming, so we will be handing it over to you, to her as well. So Mumbai is also forever in the map of our quality journey. So I request all of you to please participate in the Mumbai Declaration, give your thoughts and ideas. The Minister has already asked for it. You know it will speak, because we as private sector cannot work together. The government has kindly said they cannot work alone as well, but together we can do a lot. So namaste. Thank you all very much.
This session comes to an end. Thank you, Dr. Deepak Sawant. Thank you, Dr. Pradeep Vyas. Thank you, Sangeeta Madam. And now we can have our regular other sessions. Thank you very much.
I would like to thank all the dignitaries on the dais for the excellent comments. Thank you so much for that. Since we are running short of time, I would like to request all of you, we'll have a tea break for 15 minutes. And I would like to request all of you to please be back in the hall by 11:30. We understand that some of you are standing behind. We'll try to arrange some additional chairs in the hall. Just a quick thing to tell you, we have a very interesting session coming up, and I'm sure none of you would want to miss it. This is something nice and something different which we are doing this time. You have a very, a great performance by the drama circuit group, which is going to start sharp at 11:30. So please be back in the hall by 11:30. Thank you so much.
Hey, 1, 2, 2.
Check, 1, 2.
Check.
Check. Check. Yogmaya, check.
Two. Hey. Hello.
फिर मेरे को बोलते हैं मैं 1 मिनट के लिए बोलता हूँ मैं 1 मिनट बोलता हूँ और फिर मैं बोलता हूँ ड्रामा करेंगे फिर ड्रामे वाले आएंगे वो 3 मिनट का ड्रामा करेंगे फिर मैं स्लाइडें दिखाऊंगा फिर हरी ड्रामा करेंगे नीचे फिर मैं ड्रामा फिर ड्रामा ਇਹਦੇ ਨਾਲ ਮੈਂ ਤੇ ਘੁੰਮਣਾ ਹੈ ਨਾ check check
Whatever they say, I'll keep on typing it. So whatever you say, I'll erase it accordingly. And then we go to जब हम टाइप करेंगे, it will not be full screen. It will not be full screen. No problem. So वो half slide में दिखाएगा. No problem.
Gurmukh. One more.
Hey, check. Check.
May I please request everyone to be seated? May I please request everyone to be seated? We are about to begin our next session in 5 minutes.
Just make sure that you bear the weight of the person who's sleeping on it. This dabbas I'm worried about. No, the dabba I'm worried about.
The one of the most important is having the right facility, the adequate amount of resources, ensuring that our staff is educated and continuously trained on hand hygiene, which we do it generally by implementing various drives in the hospital like the infection control week, organizing poster competitions, collage competitions, and mystery surveys that we do on our staff. We also encourage our patients to ask the healthcare providers if they have washed their hands or not before and after touching them. This all coupled with the right kind of monitoring data that is integrated in the hospital's quality improvement program on hand hygiene is very important. This data is presented in various committees, especially the infection control committee, wherein it helps us to improve our strategies. The right kind of mix of all these 4 strategies helps us to improve patient safety by reducing infections at all our facilities.
I'm Anupam Sibal. I'm a pediatric gastroenterologist and the group medical director of Apollo Hospitals. The top 2 killers in children under the age of 5 are diarrhea and pneumonia. Every year, as many as 1.8 million children under the age of 5 die because of diarrhea and pneumonia. Hand washing can help save lives. Hand washing can save or protect 1 in 3 children who develop diarrhea and 1 in 5 who develop pneumonia. A lot of people believe in hand washing, but they believe that washing their hands with water is enough, but that's not enough. Proper hand washing means washing hands with soap. We must introduce young children to this concept of hand washing so that it becomes a habit. We must train and teach children in nurseries and primary school. In fact, we should make these children our ambassadors for hand washing so that when they go home, they can teach others. We must remember that hand washing saves lives. It's a solution that is cheap, it's effective, and it's easily replicable.
Safe patient care starts with accurately identifying the patients to deliver the correct care. Failing to correctly identify the patients and match their identity to an intended clinical evaluation or intervention or for administrative functions can compromise the patient safety. Throughout the healthcare industry, the failure of correctly identify patients continues to result in medication errors, transfusion errors, testing errors, wrongly person procedures, and the discharge of infants to the wrong families. Wrong patient identification occur in virtually all the stages of diagnostic and treatment, and therefore, as a healthcare provider, it's our prime responsibility to avoid such mishaps. The importance of correct patient identification is twofold. First, to reliably identify the individual as the person for whom the service or treatment is intended. Secondly,
Gaurav, start. Gaurav, start. Start karo. Start हुए तो
Can I please request everyone to be seated? We are about to start our next session. Request all to take their seats. We are starting the second session. Like and comment.
आजकल मैं देख रहा हूँ हर दिन नया उसमें आ रहे हो. No, no, I always wear this one.
As announced by Dr. Sangeeta Reddy, we have launched the Patient Safety Club. You can become the member of this club and enjoy the benefits of knowledge sharing. Our chairperson for the session are Dr. Suhas Gangude, ex-CEO, Godrej Memorial Hospital, and Dr. Prasad Muglikar. Dr. Gangude comes with more than 25 years of experience as a successful doctor, administrator, and teacher in both public and private sector hospitals. He's also an advisor to various software companies for providing domain knowledge for their module-based hospital information system.
Dr. Prasad Muglikar, a top management healthcare professional, comes with more than 13 years of experience in being at the leadership position and heading the medical and non-medical services as well of the premier hospitals of Apollo Hospital in India as well as abroad. The speakers of the session are Dr. Hari Prasad, the President Hospital Division for Apollo Hospitals Group, Dr. Anupam Sibal, Group Medical Director of Apollo Hospitals Group.
May I please request now the chairpersons to take over the session.
Good morning. A warm welcome from Apollo Hospitals Group and Apollo Hospitals Navi Mumbai. I welcome you for this 7th Patient Safety International Conference. It's an humbling experience for both of us after sharing the same dais, after having gone through such an inspiring inaugural session. So we, being coming in Mumbai, can we get away from Bollywood and drama and theater? We cannot, I guess. So what we have done in this session is we have actually interspersed 5 patient safety scenarios, which will be done, a commentary will be done by 2 luminaries in the healthcare, Dr. Anupam Sibal and Dr. Hari Prasad. These 2 luminaries, if I have to introduce, it will take whole day, but to give a brief on them, Dr. Anupam Sibal, who is a pediatric gastroenterologist, is also a group medical director of Apollo Hospitals Group. He has served as the only Asian JCI physician surveyor from January 2008 to 2010. Professor Sibal is an honorary clinical professor at Macquarie University, Sydney, Australia. He has served as a member of Institute Body of the Postgraduate Institute of Medical Education and Research, PGIMR, Chandigarh, from 2009 to 2014. And he has also served on the Executive Council of the International Pediatric Transplant Association. So I welcome Dr. Professor Sibal. Then Dr. Hari Prasad is another luminary who has achieved the dizzy heights in healthcare scenario in the country and beyond. He is an anesthetist and critical care consultant to start with. He is presently serving as a president, Hospital Division, Apollo Hospitals Group. He has achieved many milestones. He has created a platform and provided the impetus for establishing emergency medicine as a specialty in India. He has provided a platform to establish first operational health city in Asia and Apollo Health City. Apart from knowing for operation excellence, Dr. Hari Prasad has facilitated the launch of 2 new units in Lavasa and Hyderabad. Dr. Hari Prasad also has introduced the first formal training program for emergency paramedics in India in 1998. So I also welcome Dr. Hari Prasad to conduct this session. The drama, which will be conducted by the Drama Circuit Group, is a group formed in 2013 by Gulfam Khan Hussain. It mainly focused on street plays and skits mainly for spreading awareness and public messages. The group is an extended wing of We Care, We Support Foundation. This is a charity organization which caters to different issues in the society and is run by Gulfam Khan Hussain and her close friends. The actors involved are in the play are Suman Patel, Diksha Sharma, Khushi Dani, Pratibha, Abhay Singh, Amardeep, and Sandeep. The play is written and directed by Gulfam Khan Hussain as per the advice and suggestions provided by Apollo Hospitals to make a difference and bringing about awareness. So with this, I hand over the session to Dr. Hari to take this session forward. Thank you.
Good morning. Morning, everybody. Those who are standing, there are plenty of chairs here. Can you come and sit down? We'll give it a minute. The chairs here in the front, you can come here. All right. This is supposed to be a song and dance session, a drama session. And I decided to speak first before Anupam speaks because he's a much better actor and a much better speaker than I am. So I didn't want to do it after him, so that's why I started doing it before that. To begin with, is everybody awake in the hall?